So mantle cell lymphoma is a rare and typically aggressive subtype of lymphoma. It's about 5% of all lymphoma. I have a particular interest in mantle cell lymphoma, and BTK inhibitors are particularly active in mantle cell lymphoma. We are fortunate to have a choice of several covalent BTK inhibitors now for patients with mantle cell lymphoma, and I think it's fair to say that covalent BTK inhibitors are standard of care at the time of first relapse. There have been a number of studies that have looked at incorporating covalent BTK inhibitors into first-line therapy, and in fact at this meeting we are seeing the presentation in the late-breaking session of the ECHO trial, which I was involved in, which looks at a randomized phase 3 study looking at treatment-naive mantle cell lymphoma patients unfit for autologous stem cell transplant, and they're randomized to either chemoimmunotherapy with bendamustine rituximab followed by rituximab maintenance, or Acalabrutinib treated until progression or unacceptable toxicities. Clearly, the bottom line is that the study was positive for its primary endpoint, so it improved progression-free survival. There was no difference in overall survival, although there was a trend towards being a favourable overall survival benefit. But bearing in mind that the majority of patients who were treated on the control arm did in fact cross over to Acalabrutinib at the time of progression, which was a contrast to SHINE, which was more or less the equivalent study using Ibrutinib. So I think that that's very interesting and may change the way that we treat patients with treatment-naive, transplant-ineligible mantle cell lymphoma. We don't have equivalent data for Zanubrutinib yet. I think Ibrutinib, having been withdrawn from the US after the SHINE data, means that really it's a choice between Acala and Zanubrutinib. And I think that, there have obviously been no randomized comparisons in the second-line setting in mantle cell lymphoma, and so either one would be reasonable. There are some subtle differences in side effects, maybe a bit more neutropenia with the Zanu, maybe a bit more headache and cough with the Acalabrutinib, but it's nothing that can't be sort of managed, and they're both very effective and well-tolerated drugs. Probably the interesting thing is that Pirtobrutinib, which of course is a non-covalent BTK inhibitor, recently gained FDA approval for patients with mantle cell lymphoma previously treated with a covalent BTK inhibitor, and that is a very well tolerated and active drug, and certainly something which can be applied to almost all patients with covalent BTK inhibitor refractory MCL.